Thank you very much for inviting me along to speak to at the SRUK conference again. It's always a pleasure to be invited along to talk. And also thank you to Professor Denton for introducing the concept of autoantibodies, because we'll be touching a little more on the role of autoantibodies in the diagnosis of scleroderma. The title of my talk was actually presented to me by SRUK. They said, this is what we want you to talk about, so I hope that is what they wanted me to talk about, but we shall see. Okay, there are my disclosures. So the objectives today will be to think about how do we diagnose systemic sclerosis. We'll talk a bit about what are autoantibodies, how do we look for these autoantibodies, think about why people with systemic sclerosis may carry autoantibodies, how they help us as clinicians and how they might be able to support you as patients in understanding your disease better, and then also how SRUK are helping to support some research in this field. So there isn't a single diagnostic test for systemic sclerosis. As clinicians, we're aided on the patient characteristics. We know this is a condition that affects ladies far more often than males, for example. As Professor Denton was saying, people between the ages of 30 and 60. So the timing of the disease onset is important. Microvascular imaging is important. We've heard a little bit about the changes that you can view at the nail folds, and there are representatives here from Salford Foundation Trust who will be able to show you some of those tools. There's the clinical features that people are presenting with. So Raynaud's phenomenon, puffy fingers, gastroesophageal reflux, and no doubt we'll hear more about that from Dr. Delgado's talk. And then finally, these autoantibodies. And these all form part of a jigsaw. And when we put all those pieces together as clinicians, we step back, look at the jigsaw, and then decide what we feel the diagnosis is based on that clinical picture. So let me give you a typical referral. So there's a lady in her 80s who presented with new onset Raynaud's phenomenon. She described white discoloration of her fingers and purple discoloration of her fingers in response to cold, although that wasn't visible in the clinic setting. She developed a finger ulcer which she thought was related to getting a thorn stuck in the end of her finger whilst gardening, although she couldn't actually remember that occurring. So there's a couple of red flags here. One is that people in their 80s shouldn't develop Raynaud's phenomenon, and that should always be looked into in further detail. And then there's ischemic lesion she developed on the end of the finger, would certainly fit with a digital ulcer, although she didn't have any skin tightening. So in terms of investigation of a lady with these types of problems, we do blood tests, and the blood test on the left here shows a very typical staining pattern of anticentromere antibodies, and we'll talk more about that. We also do functional imaging. So we do functional tests using infrared thermography to look at how the blood vessels in the finger respond to a local cold challenge. And then finally, we'll look at the structure of the blood vessels in the fingers, specifically looking at the nail fold. And as I say, there are representatives here who will be able to show you this technique in practice. And these changes that you can see here in this very same lady are very characteristic of systemic sclerosis. So going back to our jigsaw, armed with all of this knowledge, we were able to make a very confident diagnosis that this person has systemic sclerosis and plan our treatment and education and counselling accordingly. So, as I say, antibodies are very helpful in the diagnosis, and it's unsurprising to see that they feature in the classification criteria that we now use to help decide whether patients have systemic sclerosis for the purposes of research studies. But what are antibodies? So antibodies are tiny proteins that are produced by immune cells that help guide other immune cells to the site of infection. They're extremely small, so I managed to work out roughly how many grams they'd be. And that is a very small, so considerably, many millions times smaller than a grain of sand. But they're very, very important. And sadly, some children are born with either too few antibodies or no antibodies at all, and they very quickly become very poorly early on in their life. And without treatment with antibodies being replaced, they would become overcome by infection. And our immune system produces billions and billions of these antibodies. And the antibodies themselves are Y-shaped, as this image at the top of the screen shows. And the shape of antibodies is very important because that cup that the top of the Y makes is actually the part of the antibody that helps to bind to other proteins, such as the proteins that are expressed on infections. And why rheumatologists are interested in these little proteins is because lots of our patients with the autoimmune rheumatic diseases produce autoantibodies. And a bit like the word autograph, autoantibodies are antibodies that are directed towards our own body's molecules. And our immune system should have mechanisms to help remove antibody-producing cells that are producing autoantibodies. But in these conditions, these cells aren't removed, and these autoantibodies can be found in the bloodstream. And these autoantibodies often target proteins that sit within the nucleus inside the cell. And we call those anti-nuclear antibodies because they're targeting the little purple ball actually deep within the cell itself. And we're able to look for these antibodies. And this image at the bottom of the screen shows a test called Indirect Immunofluorescence, which is a test we use where we light up antibodies and then we coat cells with patients' blood, and then we look under a microscope to see if we can see those antibodies. And as Professor Denton was saying, the actual staining pattern that you see on this immunofluorescence study can actually help you decide which antibodies those patients might carry. So I'd say this is one method we have for assessing the presence of autoantibodies. It's very cheap, costs about £5 per sample. But there are other tests available that can help identify which proteins those antibodies are actually targeting. So it's one thing to know that antibodies are present, but what we really want to know is which proteins are they trying to bind to. And there are slightly more expensive tests that can help establish what the protein target is. One of the big advances of the last few years has been the development of these line-based immunoassays, which allow us to look for lots of very specific autoantibodies in conditions like systemic sclerosis and myositis. And there is a very expensive test. It's expensive because it involves a lot of man-hour to actually undertake the test itself, called immunoprecipitation. And that's another very effective way at looking for these antibodies in conditions like systemic sclerosis. So what have autoantibodies got to do with systemic sclerosis? Well, as we heard earlier, systemic sclerosis is an autoimmune disease, a condition where the immune system is inappropriately targeting the body's own molecules. And Professor Denton's helped me out here, so I'll move very quickly through this triad, these three main pathological features of autoimmunity and inflammation, abnormal blood vessel structure and function, and then this development of scar tissue formation. And each of these three pathological events are very, very heavily interrelated, as we heard earlier. But why do people with scleroderma have autoantibodies? Well, that's a very good question. And we're hoping that you as patient organizations supporting research in these fields can really help us work out why. And we learned a little bit earlier as to groups elsewhere in the world who are really doing some cutting-edge research to really understand why these antibodies might get formed in scleroderma. But from our perspective, they're very helpful for three reasons. They're found in virtually all people with systemic sclerosis. Thankfully, most patients only carry one type of antibody. And they also, to some extent, help us to predict the future. And that's very important because we know that patients with systemic sclerosis, particularly early on in their disease course, when they're told they have scleroderma, the first thing they'll do is go home and Google scleroderma. And that opens a Pandora's box of terror. And we are conscious, we're aware of this as clinicians, and we try and counsel patients accordingly. I often quote this particular paper, which came out of the Canadian Scleroderma Research Group, which referred to the 15% rule. And that says that 15% of patients, or only 15% of patients, develop the more serious manifestations of systemic sclerosis. So that's roughly 1 in 6 patients. And what this study showed, looking at nearly 1,000 patients, was that about 1 in 6 patients develop pulmonary arterial hypertension, which is where you develop Raynaud's-like problems within the lungs that puts pressure on the heart. 1 in 6 patients develop a scleroderma renal crisis. 1 in 6 patients develop severe progressive scar tissue formation on the lungs. 1 in 6 patients will develop recurrent problems with ulcers in their fingers. Same for heart involvement, and same for significant inflammation in the muscles and joints. So anyone with systemic sclerosis will assume that because they've been unlucky enough to develop systemic sclerosis, that they're bound to develop all of these problems. But in actual fact, 5 out of 6 patients won't develop those problems. Unfortunately, and what keeps us busy, is most patients might develop one of those list of problems. But it's very unusual to see a patient experiencing, to any significant degree, more than 1 or 2 of those problems. So how do antibodies help us in this regard? So anticentromere antibodies, and again, actually, I'm pleased that my numbers here fit with the data from the Royal Free. So about 1 in 3 patients will carry these anticentromere antibodies. And these anticentromere antibodies have such a strong clinical relationship that they actually named a condition pretty much after patients who are carrying these antibodies, this Crest Syndrome. And many of you will receive copies of clinic letters to your GPs in which the word Crest Syndrome is used. Crest Syndrome, each of the letters of Crest Syndrome represents a different clinical manifestation of systemic sclerosis. C is calcinosis, R is Raynaud's, E refers to problems with the esophagus and the gullet. S is sclerodactyly, which refers to skin thickening on the fingers. And T is the telangiectasies, which are the small, harmless, dilated blood vessels that occur in the skin, which can look unsightly and cause problems with body image dissatisfaction, but are otherwise harmless. So Raynaud's can be quite severe in people carrying this antibody, and about 6 in 10 people will develop finger ulcers at some point in their disease course. But actually, only about 1 in 6, going back to the 15% rule, will have recurrent ulcers that are occurring winter after winter. There's about a 1 in 5 chance in developing pulmonary arterial hypertension. This is probably the most severe manifestation that can occur within this patient group. But again, that tells us that 4 out of 5 patients who carry this antibody will never develop pulmonary arterial hypertension. And if you carry anticentromere antibodies, you can be fairly confident that you'll never develop the widespread skin thickening that you'll see when you Google systemic sclerosis. It's very unlikely you'll ever have any problems related to your kidneys or any significant scar tissue formation on the lungs. So just by knowing this, there's a number of things that you can rule out will ever happen to you virtually. I'm afraid none of these rules are completely set in stone. So the next commonest antibody is the anti-topoisomerase. So on the right of the screen here, you've got the running total. So you can see about half of patients with systemic sclerosis will carry one of these 2 antibodies. About 1 in 5 patients will carry the anti-topoisomerase antibodies. These can be found in either limited or diffuse. So some patients can have the skin thickening can be restricted to the fingers, whereas in others it can be more widespread. And some patients will transition between those 2 states. Raynaud's again can be a problem, and finger ulcers also occur in about 6 of 10 patients. Again, recurrent, treatment-resistant ulcers on the fingers is rarer, only about 1 in 6, 15%. The particular condition we're concerned about with this group is the development of scar tissue formation on the lungs. That can be seen if you do specialist imaging of the lungs in about 7 out of 10 patients. But again, only about 1 in 5 patients will have severe progressive disease. And then anti-RNA polymerase 3. This is the antibody that Professor Denton was referring to when he was talking about kidney problems and systemic sclerosis. This is found in about 1 in 6 people with systemic sclerosis. It's often found in patients who develop Raynaud's in February, some skin thickening in March, and then have widespread severe thickening in their skin by June. Very, very rapid disease course. And about 1 in 3 people who carry this particular antibody will develop one of these scleroderma renal crises. And unfortunately, a number of these patients will actually present with their renal crisis. But for those who don't present with the renal crisis, it gives us an opportunity to counsel them as to the risk of this particular severe complication and encourage patients to home monitor their blood pressure and report to us if the blood pressure seems to be entering a rising trend. And this isn't about checking the blood pressure twice a day. This is 2 or 3 times a week, and just jotting it down on a piece of paper so they can keep an eye and develop a knowledge of their own body in terms of their potential disease course. And we heard earlier from Professor Denton some of the really interesting work that's linking this particular antibody with the occurrence of cancer and what that's telling us about potential drivers of the disease. So now we're down to some of the rarer antibodies. So anti-U3-RNP, this is found in about 1 in 20 patients with systemic sclerosis. It can be associated with limited or diffuse skin thickening. Lots of patients will have some lung fibrosis, although it's only severe in about a quarter, but we are concerned about the relationship between this particular antibody and pulmonary arterial hypertension that occurs in about 1 in 3 patients. Similarly, anti-THTO is found in about 1 in 20 patients with systemic sclerosis. Often have very, very little in the way of skin thickening. So it's a particular form of systemic sclerosis which is often diagnosed late because it takes a while before people think that systemic sclerosis might be the problem. These patients will often present to lung clinics because patients have developed breathlessness. About half of patients will develop some level of lung fibrosis. But again, we're concerned that sometimes the lung fibrosis can be minimal or moderate at best, but patients develop problems with pulmonary arterial hypertension. I'm aware that these talks today are being videoed, so I'd encourage you to speak with your doctors and find out which antibodies you carry, and this is a video you could watch again to see how this might relate to your own disease. U1-RNP is an antibody that's found in about 1 in 20 patients with systemic sclerosis. Often patients with quite severe problems with Raynaud's phenomenon, so digital ulcers can be an issue. Skin thickening, if it occurs, is usually fairly limited. And this is one of the antibodies that Professor Denton was telling us related to overlap features. So sometimes patients with this particular antibody will have inflammatory joint problems, or they'll actually have other overt features of other connective tissue diseases such as lupus or myositis, which is a medical term we use to describe inflammation of the muscles. Similarly, anti-PMSCL, another antibody that occurs in about 1 in 20 people with systemic sclerosis. And the actual name of this antibody, PM, related to polymyositis, SCL, Scleroderma, one of the first antibodies actually described in these conditions, and often in a group of patients who will have features of both systemic sclerosis and myositis. So as clinicians, we'll monitor the blood tests for proteins that might indicate that the muscles are inflamed. We're concerned about the development of lung problems or gastrointestinal problems. But again, overlap features generally are a feature of this particular antibody. Now we're really getting to the thin end of the wedge. So we're up to 88% on our running table, so about 9 out of 10. An antibody called U11-U12 antibody. And interestingly, even though this is the thinner end of the wedge, one of the things that we found is that with some of the rarer antibodies, the actual clinical phenotype is even more standard across patients. So whilst this particular antibody is only found in about 3% of people with systemic sclerosis, it has a very, very strong association with lung fibrosis, which can be quite severe, and also strong association with gastrointestinal disease. This was only described a few years ago, so we're still learning about this particular antibody. And then there are 9 tests, anti-RUVBL1 and 2. So this was only described a couple of years ago. It seems to be present in about 2% of patients, but a bit like PMSCL and U1-RNP, it has a strong association with overlap syndromes. And then there's the last 10%. So the last 10% seems to be evenly split between people who are ANA negative, who don't appear to carry any antibodies whatsoever, or they do carry antibodies, but they carry antibodies that aren't necessarily considered strongly associated with scleroderma. For example, anti-Rho, which you'll often hear associated with a condition called Sjogren's syndrome, where you get dryness of the mouth and eyes, or anti-Jo1, which is an antibody more commonly associated with myositis, the inflammatory condition of the muscles that I mentioned earlier. But this ANA negative group is interesting. So USTAR, which is a large European registry of patients with systemic sclerosis, have attempted to answer an important question saying, can you have systemic sclerosis without having Raynaud's phenomenon or without having an ANA, an anti-nuclear antibody? So I'd say they were two of the very important pieces of the jigsaw in one of my earlier slides in terms of diagnosing systemic sclerosis. And of over 5,000 patients, they only identified 12 who fitted this particular bill. And actually, interestingly, 4 of those patients had cancer, and one of them might have had another rare condition called nephrogenic systemic fibrosis. So there's a very good chance that if you're ANA negative and don't have Raynaud's, that you probably don't have systemic sclerosis, and that should prompt us as clinicians to look for other reasons for why you may be developing problems with skin thickening. And there are a number of conditions that can mimic systemic sclerosis that we need to make sure we don't miss or inadvertently diagnose as systemic sclerosis. But what about ANA negative systemic sclerosis? So a few years ago, I was at an international workshop on scleroderma research, which Professor Denton helps to coordinate. And I met with a young researcher called Gloria Salazar, who works alongside Maureen Mays. And she was presenting data of over 3,000 North American scleroderma patients who were ANA negative, who didn't carry any of these antibodies. And it was roughly 5% of this particular population were ANA negative. And one of the things they noted was that these patients appeared to have fewer vascular manifestations of systemic sclerosis, pulmonary hypertension or finger ulcers, but they often had diffuse skin disease and sometimes had problems with gastrointestinal involvement. So I was interested to know what tests they'd used to decide whether these patients were anti-nuclear antibody negative. And one of the tests they hadn't included was this immunoprecipitation, which is a test that we do as part of our research agenda in Bath. So with funding from the Scleroderma Society, now SRUK, we obtained a grant to look at these particular patients to see if we could identify any of the rarer forms of scleroderma-related antibodies. And we were particularly keen to do so because we'd recently described an antibody called anti-EIF2B. So I apologize for the names of these antibodies, but one of the things that was interesting about our original description of the anti-EIF2B antibodies was this very strong association with diffuse systemic sclerosis in virtually all patients, well, 6 out of 7, all of whom had evidence of interstitial lung disease. Now, one of the problems with the initial study that described these antibodies, which Professor Denton supported, was that a lot of the samples had come from the Royal Brompton Hospital, which is a large tertiary referral centre for interstitial lung disease patients across the spectrum of interstitial lung disease, but particularly scleroderma. So we, as I say, these are the clinical associations. So we took these samples from Houston in Texas using funding from the Scleroderma Society, and we looked to see what antibodies these patients carried. And there were a few interesting findings. The first was that we found a number of antibodies that hadn't been picked up using other techniques, showing that how important or the value of this gold standard method of immunoprecipitation. And then we also found 9 patients with this anti-EIF2B. And what was fascinating to find, we found the antibodies, then asked for the clinical details, and when the clinical details arrived, 8 of the 9 patients had diffuse cutaneous systemic sclerosis, and 8 of the 9 patients who'd had imaging of their lungs had evidence of interstitial lung disease. So whilst this is a rarer systemic sclerosis-related autoantibody, the actual clinical phenotype is very, very homogeneous. In other words, if you carry this antibody, it's highly likely that you'll develop a disease course that involves quite widespread skin thickening with scar tissue formation on the lungs. So this would be useful to know at the very start of the disease course rather than when the patients have developed these particular problems. So if I had to rename this talk, I'd call it the 10 tests to determine systemic sclerosis. And I would certainly say the anti-EIF2B is an important one, even though it's a very rare one. And our predictions based on our own cohort of around 300 patients, we found this in 3 of our patients. So it's about 1%. We also found some of these anti-RUV BL1 and 2, the interest being that this only the second study ever to actually describe the presence of these antibodies. And like the original authors, both patients had overlap syndromes. So we've strengthened that association. And then we found these other antibodies, similarly strange names, anti-OJ, PL7, PL12, ZO. And these are antibodies that we commonly find in patients with myositis. And we found a number of these patients. And when we looked at the clinical features of those patients, we wondered whether or not they had a very myositis-like presentation. But in actual fact, only one of the 7 patients in which we found these particular myositis-related antibodies actually had evidence of myositis. So these antibodies certainly are diagnostic for myositis and are occasionally found in systemic sclerosis, just demonstrating the considerable overlap that exists between the different forms of connective tissue disease. So we're nearing the end now, and really one of the conclusions from this is that over the last 50 years since these antibodies were first reported in systemic sclerosis, we now have about 10 antibodies that we can find in systemic sclerosis. And as we've discovered these antibodies, we've found that the number of patients who carry one of these has now risen to about 97%. In other words, virtually all patients with systemic sclerosis, we should be able to find one or more of these antibodies. And in most patients, it will only be one. So as I say, we know that virtually all patients with systemic sclerosis carry antibodies that can be measured using different techniques, some of them cheap and inexpensive, some of them more specialist. Each of these antibodies helps us to predict a particular disease course and is clearly trying to tell us something really important about the causes of the disease. And as I say, some of this work associating some of these antibodies with the presence of cancer is really tantalizing us as to where we might go in the future in terms of antibody work. Educating patients with systemic sclerosis about the antibody they carry can help them understand how their condition might develop in the future and hopefully allow them to rule out concerns about any particular disease-related complications that they may develop. Unfortunately, we have our work cut out because most rheumatology units can still only test for 3 of those 10 scleroderma-specific or associated autoantibodies. And this feeds into Dr. Lanyon's talk about the need to work together as hospitals in the UK to make sure that patients have equitable access to diagnostic tests. An important component of that is to make sure that a patient seen in Hospital A has similar levels of access to tests that are otherwise only done in Hospital B. And that's something that we're hoping to work towards. The big concern about hospitals having a limited repertoire of tests to diagnose scleroderma is a number of patients will go to those hospitals and be told they are ANA negative and reassured that they haven't got systemic sclerosis, which could lead to misdiagnosis, a delay in treatment, and poorer prognosis. Thankfully, SRUK are championing the work of international collaborative efforts to better understand the clinical relevance in scleroderma. And more work is needed to support the development of cheaper techniques to look for these antibodies outside of that specialist units. So I want to thank my colleague, Professor Neil McHugh, who runs the immunological laboratory at the University of Bath. Also, Maureen Maines' group in Texas, who supported this work that we've undertaken using funding from Scleroderma and Raynaud's UK. Colleagues within the UK Scleroderma Study Group. And finally, and not least, the Scleroderma Society and now Scleroderma Raynaud's in UK for giving us as researchers the opportunity to develop an interest in systemic sclerosis and try and undertake work which will turn full circle and come back to help patients. So thank you very much.